is a 31-year-old female presented to our center with diminution of vision in both the eyes, and there was patient has malar hypoplasia with broad nasal bridge and a beak nose, and she was one-eyed. You can see that in this eye she had no vision at all. She was PL negative, and in the other eye, which was which did not have opacity, it had a anterior staphylomas which was present as is seen here, and basically it is a Trabowsi syndrome in which there are multiple cystic blebs, just like you have trabeculectomy blebs. This was the other eye, that is a left eye, and this was PL negative because of the same thing, that is the multiple cystic blebs which cause the AC to become shallow, and primary angle closure glaucoma is there. So in this case we wanted to repair it because we did not want this eye also to have the same fate. So peritomy was done in this case, and the bleeders were cauterized. 1 millimeter entry was made on the staphylomas using MVR blade, and subsequently side port was made at the limbus, and anterior chamber was found with the OVD. Now subsequently the lens, the crystalline lens which was subluxated, was expressed out with the help of the viscoelastic agent, and this was subluxated, so it had to it was not possible to do a phacoemulsification in this case, and then ciliary processes were visualized, and consequently the continuous interlocking sutures were placed with 7-0 bicameral suture, and scleral ends were opposed. Now, after having done this, we triphinated corneoscleral rim so that we have about 4 millimeters all around, and this was cross-linked. And after triphinating it, this was split into two parts, and two wedge-shaped marks were placed on the cornea, and tissue was excised in between the marks. Consequently, this was placed on the staphylomatous area, and we also prophylactically placed it on the other side also, because that also would have undergone the same fate. A small pocket was created to tuck it in inside the area which was dissected, and sutures were applied with 10-0 monofilament nylon sutures. Now consequently, in the other side also, because otherwise, because of the cystic blebs, the AC would have become shallow, and this is genetically determined, and there is a special gene which has a propensity to have this multiple cystic bleb feature. So here also, on the other side also, this was put so that the patient does not have it. The patient does not have a similar fate as in the fellow eye of PL negative, and this was in the post-operative period. So this was a tough case to do because already there was glaucoma which was present, and cup disc ratio was to the tune of 0.7:1, and you always are fearful when you address these cases that the patient might lose the vision which is there, which is already existing. So thank you very much for your kind attention.
Thank you, Dr. Namrata, for a very interesting case presentation. These cases will really have a lot of difficulty in following up in terms of glaucoma follow-up.
Yeah, so they have to be followed up. They do have a difficulty in glaucoma follow-up, but ours is a cornea plus glaucoma, so we have glaucoma surgeons over there who take care of it. In fact, this case was referred from them to us.
Very nicely managed. Any comment from anyone? Okay, can we move on to the next speaker? Dr. Rohit is ready.
Thank you, Dr. Rajesh Sinha and Dr. Bharti for the opportunity. So I have been asked to take up posterior capsule rupture. Well, whenever a PCR occurs, the question is what next? We all are aware of signs of posterior capsule rupture. We are aware that there should not be any panic mode. We should have stable chamber settings. We should evaluate after stable chamber settings the amount of PCR we have. Then we have to strategize, use triamcinolone to see what the situation is, use anterior or posterior vitrectomy and complete the case if we can. So now let's see this case scenario. In this case scenario, what is happening is that our fellow, she's trying to do sculpting, and while sculpting, she has reached the posterior plate. She should have stopped, but she continued and created this situation. Now with this situation, she was intelligent enough to realize the problems associated with it. So she just got up, called for us and handed the case to us. Now the question is, when the patient came to us, we had a specific surgical plan. We shifted to lower IOP to physiological IOP settings. We knew we have not to rotate the nucleus. We had to do slow motion phacoemulsification, use IOL as a scaffold if required, do supracapsular emulsification, do IOL capture and move on with the case. So the IOP settings which we decided would be 20 millimeter of mercury IOP, and which would boil down to 27 centimeters bottle height. The flow rate would be around 23. So now let's see what happens with the active fluidics, which no financial interest whatsoever. We use slow motion phacoemulsification as shown by Robert Osher and our own Dr. Abhay Vasavada. So the first thing which we did was injected visco to just tamponade it. Low IOP. Now with this low IOP, what was happening was, there was hardly any undue excess of fluid into the anterior chamber, and subsequent to which the vitreous phase was not being hydrated. The stable chamber settings created a situation in which the anterior hyaloid phase was not being broken. The nuclear fragments were floating in the anterior chamber, were made to float. They were not being pushed behind. The chamber was not overly deep. The emulsification was continued in a slow motion manner. And while it was being continued, we were very sure of the fact that with such low IOP settings, we were creating a situation where we would be able to convert the anterior hyaloid phase from a foe to a friend, to an ally. So this was being continued in a slow motion guided manner. And once that was done, the next step was, this was possible because we were using a calibrated side port incision, which was not letting the chamber become unstable at any point of time. Then we used the stable chamber settings. Now we came to the irrigation aspiration. Ideally, we should have gone in with a bimanual IA, but in this condition, what we have done is, with low IOP settings, we have retracted it slightly. I would have been more comfortable in the hindsight had I retracted it more, but the most important thing is that a bimanual could have helped. Since we are always used to using calibrated side port incisions, we do not have calibration as such as of now by calibrating the two side ports had we used a bimanual IA. So we made a compromise by, retracting the sleeve to a large extent and continued to do IA with low IOP, with low infusion of fluid, stable chamber settings again, then did dry aspiration using the great Gills-Welch technique, and the case was completed. IOL implantation was a 3-piece IOL. I could have rounded off the posterior capsule and implanted a single piece IOL. Triamcinolone staining showed that there was hardly any vitreous in the anterior chamber. I think I can show you the post-op. Let's forget about it. So now moving on to the next case. So this is another case in which there's a fibrotic cataract. The left eye, the other eye, is pseudophakic with optic capture. Now what did that mean? It meant that the posterior capsule might have been ruptured. So we had to be wary of that because the patient had delayed it because he was not comfortable of the vision and he was in a way, fearful about getting the surgery done. As would have been, we went in for a smaller rhexis because we wanted that if by any means we had to do, an optic capture, we should be ready with it. So once that was done, sculpting was started, a small gutter was created, and then chopping was done the way Abhay Vasavda has taught us, multi-level chopping at different levels and at different places to achieve total separation, which I was able to. Then the nucleus, this is at 2x speed, the nucleus was chopped, totally separated. I thought I was going on nicely, and suddenly you will find I realize that there is a posterior capsule rupture. So the patient was already very, apprehensive about it. Now the question is, what next? Again, same thing, lower the IOP, no rotation, slow motion, phacoemulsification, IOL scaffold, supracapsular emulsification, do IOL capture and everything. Now with this low fluidics, what the aim was that this creates a situation in which these small fragments, they touch the anterior hyaloid phase and they come back. So let's see what happens. So what I did was I brought it forward and I chopped it fully because I wanted to do it because I knew that the IOP was overly low and the nuclear fragments and the fluidics would not push it behind. So with this 20 millimeter IOP and 26 flow rate, I was continuing in a slow way. You would find that I'm moving in such a way that there's hardly any chatter. So this has to be done in a very, defined way so that there is not high degree of, chattering is there. Then at this point, I was caught on the wrong foot because the capsule was open. The half heminucleus was there. So the click was, I had to rotate it. How do I rotate it? You can see it is not overly inflated with the, wrinkles there. So I moved slowly enough so that I do not push it behind. And the moment I passed it, I thought that I had been able to achieve what I wanted to. So I pulled it forward, but then it's a large nuclear fragment. So I thought I'll chop it again. And once I chop it, then I will use Dr. Amar Agarwal's technique of using IOL as a scaffold, where what I would be doing I would be putting the IOL, here the IOL is going in. The nuclear fragments have been pulled forward because of paucity of time, I'm just ran forward. So I'll just place it on the iris or in the sulcus. Now what has happened is I can go deep because there's a artificial posterior capsule and an anterior, the cornea will be protected because I'll be working at a deeper plane with a slow motion manner so that there is not much of, I can use, the chopper as a shield also, stable chamber settings, and with the stable chamber setting, the case was completed. Here the IOL, it was being dialed in, IOL as a scaffold, then it was, optic capture was done, and the patient was very happy. Thank you very much for your kind attention.
Thank you, sir. That was really wonderful. Two very interesting cases, and definitely IOL scaffold is one thing These days, a lot of people are now, I mean, there are some specially designed lenses, soft lenses, contact lenses kind of a thing also.
Absolutely. Dr. Sanjay Chaudhary has come out with, and he says that it takes this thing, but then you have to take it out. All these things are involved in it.
Absolutely, absolutely. You have to put it and then you take it out. And,
absolutely.
And plus, the IOL will be more rigid to sustain the pressure of fluid. Soft lens may sometimes
Give
slip
way.
And
there can be,
create problems.
absolutely correct.
Very nice cases.
Thank you.
Thank you very much.
Thank you.
We now invite Dr. Sudhang Bharti for his talk on new kid on the block for all grades of nuclear emulsification.
Good afternoon. Thank you, Dr. Sinha, for inviting me. And so I'm talking about the new machine which has been introduced by NIDAC in India. This is a new system of phacoemulsification, and I've been using it. I thought there'll be a couple of other users also here, but Maipal has probably left. So what we require in a good machine is balance of safety and efficiency, and this is what we are looking at. So the Cube Alpha, as the machine is now known as, is having a torsional US oscillation with torsional US tip, and a new sleeve for enhanced fluidics, which is actually gives you a much better control of the chamber, and there's hardly any surge. So what is torsional? Longitudinal movement is a conventional oscillation method. It is suitable, but sometimes because of the longitudinal movement, the nuclear fragments are pushed away. Whereas in the torsional movement, the nucleus is not pushed away. And that is the reason why torsional is now the way to go, and it maximizes US energy delivery and improves the holdability. The NIDAC system calls it gyro, and the gyro system, as this video shows, it's a different handpiece, and the tip is slightly bent downwards, and it goes both longitudinal and torsional or gyro movement. So as soon as it is there, the emulsification is much faster and is taken away in the tip very quickly. So it allows more efficient cataract surgery, and there is an on-off time and longitudinal torsional oscillation ratio, which allows one to or both of them to work together for a more efficient phacoemulsification. The frequency of longitudinal and torsional is slightly different, and it's a very light handpiece. So here if we see, with the normal gyro tip, there is hardly any movement, as you can see in the water, where the nuclear fragments are lying, as compared to other torsional tip, where there is a lot of turbulence, and this turbulence translates into turbulence which is happening in the antechamber also while the surgery is being conducted. So also there is another new thing about this gyro tip. There is a small hole, which when the nucleus piece is held in the tip, even when the machine is on, it does not heat, the tip does not heat, and because the fluid flow continues. Whereas if there is no hole, it gets heated and causes wound burn. So that's another factor where this small hole works. It's about 0.13 millimeter size hole, which cools down the tip all the time. So as you can see, if it is a normal system, no flow, there is a temperature goes to about 65 degrees centigrade with a hole, and with the big side hole, it goes hardly 30-35, which is cannot cause any wound burn. Also, the new Neo Sleeve series has got a large hole here, which causes more flow of fluid into the antechamber, and gives a lot of more stability. Here you can see this hole is much larger as compared to the conventional sleeve. So under the pseudo incision, if you see, there is the micro sleeve, it spreads the fluid all around, and it causes better fluid dynamics and enhances the followability and lens holding. So this, gives you a much better control, while you can go up to a higher vacuum without much of an issue. Like even with the 500 vacuums, the flow and the irrigation remains very, very stable. This is my case with the system, NIDAC system, and here you can see the parameters which I am using, and for the sake of demonstration I am using, okay. So as you can see, the holding and followability of these nuclear fragments are very quick, and hardly any heat is generated, and the chamber stability is absolutely fantastic during the surgery, as you can appreciate. Without much difficulty, we can do the phacoemulsification with this system. It allows the chamber to be very, very stable, and is comparable to any other best system in the market available today. And also the other thing is that it has got a reusable tubing, so that you can use it for many times, and it is not a disposable system. So it is, it brings down the cost of the procedure cost every time. So that also is one reason why this is a very small and efficient and a compact machine. So this is, you can see that you can use a 600 vacuum without much of an issue in all these cases. And I'll just demonstrate one case where the cataract is very hard. And as you can see, this is a very hard cataract. Already rhexis is already completed here, and this same machine is being used, the Cube Alpha, and you can see the cutting power and the you have to see the cutting for this grade 4 plus cataract, and I have to really use the maximum power for emulsifying and making a trench or to hold, and to make it a little deeper to hold and then to chop. And in all these cases, even with the best machine, sometimes there is a possibility that you will have a little bit of trouble using it in such a hard cataract, which is very, 4 plus. But it's not very difficult in these cases where the cutting as well as vacuum which you're using is approximately 500 to 600. And all these cases you can use it for even with the hardest of the cataract, you can chop it without much difficulty. And you can see that this kind of cataract can be easily used, this machine can be used. The only thing about the hard cataract is that while you're chopping, you are all behind the rexes. But once you are trying to emulsify, either you remain at the plane of the rexes, or you have to, keep on injecting viscoelastic, so that there is a, possibility that you do not touch the endothelium and the, posterior capsule, so that the safety is, ensured. In these cases, if you want to use a machine like this, where there is hardly any surge, it is possible. But when you're using a power of nearly 100% or 80% in all these cases with a high vacuum, there is always have to be a element of safety. And as you can see, after the chopping, this machine can take care of the hardest nucleus with very, very comfortable and emulsification of the quadrants, and continuously you can use the system to emulsify. And only the first, the first quadrant is slightly difficult, where you're trying to assess as to how much power is required and what kind of fluidics you're looking at. Once you have emulsified the first quadrant, then subsequent quadrants are easy to manipulate and manage, because this is something which this machine can take care of this kind of hard cataract also very comfortably. Once you started doing it, then it gradually emulsifies very easily these things. I'll take about a minute more. So this is the hard cataract which you can emulsify without much difficulty in all these cases. And you can see the efficiency and safety of this machine is very, very good, and is comparable to the best in the market available. The only thing is that I want to use, and this is one tip I want to give to all the surgeons who are trying to emulsify a hard cataract, that you keep on injecting the viscoelastic in the antechamber. It brings the temperature of the chamber and the endothelium down. Also, it gives us a buffer, and there is a space available for doing this whole emulsification very, very easily and comfortably. So as you can see, this is how you can use the machine to emulsify hardest the cataract with utmost comfort and ease in all these cases. And this is the micro neo sleeve, using the micro neo sleeve, which has got a very high irrigation, possibility of high irrigation. And this sleeve will be, kind of very, it makes the chamber much more stable. As you can see, the sleeve port is much bigger, and it allows the continuously larger, about 1.5 times the normal flow which is available with a normal sleeve. So this large port is making the chamber even more stable, and there is hardly any heating of the phaco tape, the phaco probe, and there is no possibility of any wound burn in all these cases. And with this high irrigation, high volume irrigation flow, you can see that the chamber stability and also the possibility of doing everything with a comfort is very high, and you can very easily emulsify even the hardest of this. This is again a very hard cataract. It is not something which is normally we see once in a while these hard cataracts, but this sleeve keeps the tip cool and keeps the chamber stable in all these cases. And of course, the power delivery because of the gyro tip is again, it takes the, emulsification of the nucleus very easy even in the hardest of the cataract. So this, I think, it shows the efficacy and safety of the system, which is very nice. And I've been using earlier I was using the CV9000, but this is even better when this new thing has come in last about 3-4 months. This is very efficient and makes my life much more comfortable as compared to any other machine. I have other machines and other centers which I'm using. So this is thank you very much.
Thank you, sir. And it was a very nice presentation. I'll request Dr. Priya to put up your presentation. Just one question for you, sir. It does have longitudinal and torsional together at all times?
No, it is possible that you can have one at a time or both together. So you can have alternately and you can have them together, and you can have cooling off time also. There will be on-off time also. So both can be on at same time, on-off two differently, and on-off for a while, so that you can manipulate whatever you want to, whichever way you want to manipulate the nucleus and keep the tip cool.
Okay.
Yeah.
Okay. Thank you, sir.
Yeah.
So we have Dr. Priya now with her interesting case.
Good afternoon, everybody. Thank you so much for this wonderful opportunity. And well, today in the cliffhanger cases, I will be just showcasing one case, and it's a real challenge when we happen to see these cases. So this is a patient with a history of trauma, and this patient has come up, and on examination, things don't look quite good for this case. So we take up this case in the OR, and as you can see, we're just waiting for the entire story to unfold. So the moment, the conjunctival peritomy is done, and we try to analyze this, I'm trying to do things very delicately, trying to retain as much as amount of iris tissue or things that I can, but suddenly, something hits my Caesar, and I see that, okay, these are the haptics of the intraocular lens. So I know that there is an IOL, so it's just like a pseudophacoceal kind of a thing which is present out there in the section. So probably the previous surgery, when it was done, the section has given way, and maybe it was a small incision surgery. So the sclera has given way at that point of time, and this is the one-piece intraocular lens that was then explanted from this. So then carefully you suture up the entire sclera out there, and fluid infusion is there inside the eye. Things are not very clear at this point, so we really do not know how we are going to go ahead. But one thing is clear, that we need to do a secondary IOL fixation. So my procedure of choice is to do a glued IOL. 2 partial thickness flaps are made, and I deliberately highlighted this because the moment I did a sclerotomy, when my needle came out of the eye, it was stained yellow fluid. So I understood that there must definitely be a blood out there in the area. So I go ahead with the 23 gauge cutter. This is trying to clear off everything that is present in the anterior chamber. There's a lot of hyphema out there. This procedure, cleaning up, takes a lot of time. So, actually the surgeon has to be quite patient, because we do not know what's going to unfold next in this patient. Luckily, I could see that, yes, things look quite good here. It was just out there in the anterior vitreous that there was a problem. The glow is good. So I decide that, okay, now this is a point that we can go ahead with the secondary IOL fixation. So this is a 3-piece intraocular lens for the glued IOL procedure. Just hold the tip of the leading haptic and waiting for the entire IOL to unfold. Once it has unfolded, the leading tip is externalized. Now this is a no assistant technique which was described by me. The leading haptic does not slip back, and you don't need any assistant to hold it. followed by the handshake technique, which is a transfer of haptics from one hand to another, described by Dr. Agarwal. Now, these are the haptics that are being tucked into the scleral pockets. This is what gives strength to the intraocular lens fixation in the gluteal procedure. So we at least need about 2 to 3 millimeter of good haptic tuck into the pocket to give stability to the case. So things, they start quite looking good, when the intraocular lens is fixated for this patient. The only thing that I had a query was that, there was a lot of iris defect out there, and I was trying to retain it, but I had to cut it off because it was all charred. Now, in this case, I was not very sure that I will be able to do a pupilloplasty, but I said, no, I need to do something because it's a very big defect. Let me try. If it gives way, it gives way. I won't do it again. So taking up my chance, I'm doing a single pass photopupilloplasty procedure. A 9-0 polypropylene suture is passed through the proximal and the distal end. We need to be very careful in these cases because the iris tissue is quite friable. And now this is the suture loop. That is the end of the suture. It goes through the suture loop 4 times in the same direction, and we pull both the suture ends together. Once you pull both the suture ends, it automatically slides. Now, I was very careful at this point that, okay, it should go on to slide very slowly, effectively, trying to create an effective pupil for this patient. So I was quite successful, and I was quite surprised too that actually I did not expect this to happen, but it happened. But then there was nothing much that I could do. Now there's a much more bigger peripheral defect, but absolutely no presence of iris tissue. I cannot close down that defect. But then there was something in my mind that, okay, yes, this can get covered by a little bit by the upper lid, the upper palpebral tissue. So that would seem good for this patient, and this patient did quite well in the postoperative period. So, well, this was one case. Do I have time or should I close down? Can I? Okay. Okay. So, okay. I showcased this one video. This was one of my longest days in my OR. I began with this mature cataract. It was again a history of trauma, so I always start with staining with triamcinolone first to see any vitreous. It was not there. So I said, okay, come on, I go ahead with the normal cataract extraction, how everybody goes ahead. Let me go with the trypan blue and all that. So I try to decompress this. I did everything which ideologically is described for these cases. So going very carefully, I'm trying to create a mid-size of capsulorhexis for this patient. Everything is done quite well. But actually what happens is that when I come up in this zone, things start getting difficult for me. I don't know why, because the tension was not there in the capsule. And this point, when I tried to convert it with the capsulorhexis forceps, it was giving a pull. So what I actually do is I just cut off the flap with the scissor because I don't want any complication coming up in this patient. So I went ahead, I did an IA, but the moment I came out of the eye, I could see that yes, this is a problem here. And actually in that area, even the capsulorhexis was not complete, and because there was overstretching, probably the zonules were not there supporting, although there was no vitreous out there, but the zonules were not there supporting this. So anyway, I could not put a CTR because the rhexis is not complete in this patient. So I just decided that, okay, let me take a 3-piece IOL. The second best step that I can do is let me do it, and I will place the haptics in a way that, I can do a sulcus placement of intraocular lens in this patient, because almost more than 3/4 of the rhexis was good for this patient. But somehow even the IOL was also not stable. I tried to stabilize it, but it was not taking up, and I was not ready to close the case like that. So I decided I need to do something, fixate it so that, I do not have any problem tomorrow. So what I do is I create 2 flaps again. I already have a 3-piece IOL out there. Fluid infusion is going on, and I'm doing a sclerotomy. I do have a capsular bag also behind, but then I thought I'll remove it later on. So I go ahead, I do my glued IOL procedure. I still have a capsule which is behind there, and it is supporting my intraocular lens very well at this point of time. So there's no frank vitreous that has still come up out there. So this is the glued IOL procedure which I'm doing, and I just externalize the haptics with the no assistant and with the handshake technique. But see now, there's a lot of kinking of the haptic out there. And this haptic, I'm trying to tuck this haptic, but it was not going inside. And so I mean, this is an edited video. I was so disgusted at that point that I don't know why this is not going. So what I do is that I do a limited vitrectomy out there. I fixate the other haptic first, And then I come back to this and I just take up this plug of the iris hook and I just slip it onto this, because I know I need to do additional procedures and I don't want this haptic to go back inside the eye. So I want to fixate this out there delicately. This plug will hold on to my haptic during the entire procedure. Now what I'm going to do, so I create another sclerotomy. This is beneath the flap, so that I don't have any issues of sealing it up again, because I need to clear up the entire capsular bag, the subluxated bag which is present behind the intraocular lens. So I'm going behind doing this vitrectomy. It's just like doing a pars plana vitrectomy out here, from behind. This works beautifully. Everything is cleaned up in this patient, and then again I try to stain it and then trying to remove all the vitreous that is there in the anterior chamber. Having done this, I know there can be an optic capture too at that point of time, so I'm trying to prevent that by doing the pupilloplasty procedure. This is again a single pass 4-throw pupilloplasty procedure. This again works beautifully. Many times, what happens is whenever we do a secondary IOL fixation post-operatively, if the size of your pupil remains the same as the size of the optic, then it can do an optic capture. It goes into an optic capture, and specifically when you are a bit working in the anterior plane and if your IOL is fixated that way. So if you don't want that to happen, many times we do a pupilloplasty in one zone, so that the size of the pupil is slightly less than the size of the optic of the intraocular lens, so that you don't have that problem coming up. So now I decide that, okay, now I'm going to tuck this, and I don't know for what reason it goes off very easily inside. Probably there was some kind of stress or tension coming up from behind which got cleared by doing a good amount of vitrectomy. But still, I know that there's a kink in this haptic, so I'm still trying to fixate it up, double securing everything. I took up a suture, fixated up, put up a glue, and things went off well, and patient behaved very well in the post-op period. Thank you so much.
That was really interesting. Two very difficult scenarios, and the last one, you purposefully put one suture also to stabilize it so that it doesn't slip back.
Absolutely, because if you would have seen, there were 2-3 kinks kind of a thing. So I did not want it to come out of that and again go back into the eye. So I just took an extra suture to fixate it and then sealed up everything with glue.
Okay. Thank you. Thank you.
Thank you. Thank you, Dr. Priya. Now I will invite Dr. Rajesh Sinha to showcase his presentation on phacoemulsification.
Okay, thank you, sir. I'll be showing one case from moving on from the glue dial cases that Dr. Priya has just now shown. I'll show you a case wherein this is a case of a megalocornea in which glue dial was done normally, routinely, the way most of the times people do, with haptics fixed along 3 and 9 o'clock positions, and the haptic slipped later. And then this patient was referred to me. So we saw that because this in megalocornea, the corneal size is large, and if you create the groove a little peripherally, a little more, posteriorly, like normally we create a groove about 1.5 to 2 millimeters behind the limbus, at least 1.5. But in megalocornea, again, what happens that since the cornea is large, the haptic has to traverse greater distance, the risk of slippage is high, and that's why in this particular case, it slipped. So when the patient came to us to show, the patient was looking aphakic, had a sudden drop in vision, and on paper it was written that there is glue dial that was done. So then we saw the patient, the pupil was not fully dilating, but this much it was dilating, measured the size of the cornea, and then decided to go for a limbal flap, posterior limbal, just behind the limbus. We will create a flap and a groove just next to the limbus, and vertical, not horizontal, because vertical white to white is smaller than horizontal white to white. So then the haptics will have to traverse a shorter distance. Now, if you are creating a a flap and a groove vertically just next to the limbus, then in that case what normally happens is that I don't create a Shariat pocket, I just dissect with the crescent blade beyond the second incision so that I get a groove there. Now as you can see here, the flap is right at the limbus, and here will be the, just behind the limbus will be the groove. So with the help of a 2 Sinski, I'm trying to stabilize and pull the IOL haptic so that I can hold it with one forceps and then bring it anteriorly. If the haptic that had slipped was brought anterior to the iris, and then the IOL was rotated reverse so that it comes out of the pocket on the other side, and then holding with the Sinski hook and then holding the haptic with the forceps, because one haptic was already over the iris, both the haptics were brought anteriorly. So now you are safe. It will not go behind. And then, as you can see here, I'm just going just behind the limbus. Now, if you are going just behind the limbus, there is an issue that you can damage the root of iris. So in this case, I'll just pause here and show you that what I'm doing is that I have gone creating a small peripheral iridectomy, small peripheral iris hole, so that I will pull the haptic through that hole, and that will make a shorter route, and that's why there will be greater size of haptic that can be tucked, and plus it will be supported also by the iris. So this is what is being done here. So this is the peripheral iris hole through which the forceps is being introduced, and with handshake technique, the one haptic is held, and then it is brought towards the pupil. The tip is held with the other forceps, and then it is exteriorized. So one side exteriorized, and this is out, and then the other side again you can see I am going through the peripheral iris hole. I have created a hole and then holding the second haptic and then exteriorizing it. So this haptic has come through the hole and through the opening, stab incision made just behind the limbus. So it has to traverse shorter distance, and that too vertically. So it has to traverse shorter distance, and that's why we have a greater area, greater segment, greater length of haptic that can be tucked, so that we can have absolutely negligible chance of slippage. You can see how much of haptic is out, and the iris supports as well. And the second thing is that the risk of anterior optic capture is also lesser in these cases, if you make a small peripheral iris hole through which if you take out the IOL haptic and then tuck it in. So this is what has been done, and then the wound is stabilized, and I'm sorry for that. So all the incisions is hydrated, and then fibrin glue is put in place, and the patient has a follow-up of about 17-18 days. It's a recently done surgery, and the IOL is well centered and well stable. So thank you very much.
That was a great talk and very good teaching points that you mentioned during your video. It was fantastic. Thank you.
Would like to know from you also, have you tried this, taking out through a peripheral iris hole if it's a very large cornea?
Yeah, we do. I do it specifically the peripheral iridectomy kind of a thing. That
Yeah.
in cases of high myopia
Yeah,
patients.
high myopia
Yes.
or the pure
Not specifically for
cornea is large.
Yes, you
then
can always do
yeah.
it. It works brilliantly and it prevents, pulling the dragging of the iris tissue when you're making a sclerotomy. It's a brilliant move.
Thank
Yes. Thank you so much. So, are you presenting?
Done.
Okay, thank you. So now we move on to Dr. Raghav, and he will be talking upon his cliffhanger case.
Good afternoon, everyone. Thank you, Priya ma'am, Sang sir, and Rajesh sir for this opportunity. So I will be moving away from cataract surgery and going into refractive surgery a bit. This is my cliffhanger case. This case happened recently, and it actually was a cliffhanger where both the patient and I were stuck. So this is managing retained lenticles. So whenever we do a refractive procedure with lenticle extraction, there can be condition where there can be an area which is left uncut, and in the pocket a part of the lenticule can be stuck. So removing that is not the easiest task. So if you see what is the etiology, when can we have such a remnant lenticule? The most common is having a black spot or a secretion of mebum on the cornea while the laser is firing. There can be a foreign body like an eyelash that comes between the cornea and the dock. Very thin lenticles can have breakups of the lenticles, and also for very difficult dissection or someone who is a trainee. So the prevention is, as soon as the lenticule is out, you should always inspect to see that the lenticule has come out wholly. And the major question is to treat or to not, whether that remnant lenticle should be removed or not removed. So dictum is, if it is causing a change in refraction, causing irregular astigmatism, it should be removed. So this is one case that was referred to us. This is the area of retained lenticle, which you can see. Similarly, we see that steepening on the topography map, and also in the AIOC we can see a remnant lenticle. To remove this, Dr. Gidansha has prescribed a technique of injecting triamcinolone inside the pocket to delineate this lenticle and remove this. And also with the intraoperative AIOC and with the circle software, this can be removed. So this is my case. So this is a patient that we were operating on, was undergoing silk. If you can see, there is a small area which shows there is a small uncut area. Once you try and do a dissection in the anterior plane, the anterior plane comes out pretty easily. On the right, you can see the AIOC. In the AIOC, we can see we are in the anterior plane, and pretty easily the anterior lamina is dissected. Once that is done, then we try and go on to the posterior plane. So once we go into the posterior plane, we can see there is some area of difficulty in this area where there was a cold spot. We try using a duck-billed spatula to try and remove the lenticule, and we do a thorough dissection, and we are able to remove the lenticule. Once the lenticule is out, we inspect it, and you can see there is a small triangular pie-shaped area of lenticule which was left in situ. So we know that there is some part of the lenticule left inside, and luckily we have the intraoperative OCT, so we can see that there is the retained lenticule. Then again we spread it out, and this lenticule is discarded, and then we go again into the pocket. If you can see this cube of the anterior segment OCT, we are decreasing the size, that is the resolution is being increased. Once you decrease the cube, the resolution on the right increases. And we can see there is a small area of retained lenticule. This is what we are trying to remove. We are dissecting again and again and trying to remove that lenticule. If it stays in situ, it can cause irregular astigmatism. Again, this AIOC is showing us this area of irregularity where there is a stuck lenticule. We again try and remove these remnants, and we use a globe stabilizer to stabilize the globe, and use a forceps to remove as much as possible. And then we put a BCL, and we see the patient post-operatively. This is on day 1. You can see the patient has a small remnant lenticle fiber. The patient was 6-9 parts with the BCL on, and the AR shows a 1.5 cylinder. And then the patient is kept on steroids and thorough lubrication. And the patient at 1 week, if you can see, the patient is now plano. Patient was 6'6" without the BCL. There is a very small remnant lenticle in the pocket, but this is not causing any change in refraction or decrease in vision. So this is how we manage this case. Thank you.
Thank you, Dr. Raghav. And I mean, we keep facing such scenarios, particularly during our learning curve, or at times even if we have learned, if we become a bit casual, then these things can happen.
Yes, sir.
Any point you would like to add, sir, or conclude?
I think this is one thing which one has to, all the beginners should see that how to, separate and ultimately without breaking and leaving the small fragment.
Yes, sir.
You take the whole thing out, but ultimately it may take a little time, but it becomes fine because the whole system is such that nothing normally goes wrong unless you have created a lot of issues.
Yes, sir.
So in any case, you did it and, controlled it well. So congratulations on that. And I think if there is no questions, we'll conclude the session here. And thank you very much.
Thank you, sir.